Thank you for that introduction. We have no disclosures to report, and as we know, despite suppressive art, HIV persists in anatomical reservoirs throughout the body, some of which are shown here, including the brain, lymph nodes, and the male genital tract. And HIV localizes in male genital tract organs and the semen during chronic HIV and in men on ART who achieve viral suppression in the blood plasma. And this HIV persistence has downstream effects. HIV persistence leads to male genital tract inflammation, which has the potential to increase transmission risk. And this HIV persistence may be exacerbated by subtherapeutic antiretroviral concentrations in this compartment. And previously, Fernandez et al. Reported total and protein unbound CAB and Rilpivirine seminal plasma trough concentrations and found that protein unbound CAB concentrations exceeded in vitro EC50 values, but protein unbound Rilpivirine concentrations were lower than in vitro EC50 values. However, data regarding CAB and Rilpivirine seminal plasma concentrations throughout the dosing interval have not been reported. So our objective was to define the pharmacokinetics of long-acting CAB and Rilpivirine in blood plasma and seminal plasma throughout the dosing interval. Towards this, we aim to quantify both of their concentrations in both matrices throughout the dosing interval, determine their protein binding potential in both matrices throughout the dosing interval, and estimate protein unbound concentrations in both matrices throughout the dosing interval. Our study population included adult cisgender males continuing bi-monthly CAB for PrEP or CAB and Rilpivirine, and we excluded individuals with acute HIV infection, hepatic or renal impairment, or active opportunistic infections. And here is an example of our ideal sampling scheme for an individual either on CAB or CAB Rilpivirine. We aim to get time-matched blood and semen samples, shown here as blue and red teardrops, before their dose, 3 to 4 days post-dose, 7 to 10 days post-dose, and then every week thereafter until their next dose. And because this would require weekly clinic visits by our participants, we offer an alternative sampling scheme which requires these first doses, the prior to next dose samples, and one additional pair of time-matched samples at any of these time points. Antiretroviral quantification was performed using UPLC MSMS methods, and rapid equilibrium dialysis was used to determine protein binding potential. For our PK analysis, we estimated protein unbound concentrations in both matrices by multiplying the percent protein unbound by the total concentrations, and then total and protein unbound seminal plasma to blood plasma ratios were calculated by dividing seminal plasma concentrations by their respective time-matched blood plasma concentrations. And then finally, total and protein unbound AUC tau values were calculated via non-compartmental analyses, and similarly, seminal plasma AUC was divided by blood plasma AUC to get the same ratio. We've so far recruited 10 participants who have provided a total of 22 time-matched samples, half of whom were on CAB alone for PrEP and half were on CAB and RPV, or Rilpivirine. The median time on their regimen was 95 weeks, suggesting that we received these samples while they were on steady state. And here I'm going to show the total CAB on the left and Rilpivirine on the right concentrations throughout the dosing interval. The y-axis is concentration in nanograms per mil on a log scale, and the x-axis is time in days. This horizontal dashed line represents the PAIC90 for CAB. And we can see median blood plasma concentrations represented by these red points exceed the PAIC90 throughout the dosing interval, as we would expect. However, seminal plasma concentrations, shown here in blue, are below the PAIC90 throughout the entire dosing interval. And we see very similar trends with Rilpivirine, blood plasma above the PAIC90, and seminal plasma concentrations below it at a majority of time points. Overall, this resulted in total AUC seminal plasma to blood plasma ratios of 0.01 for CAB and 0.08 for Rilpivirine. And now I'm going to share the seminal plasma to blood plasma ratios throughout the dosing interval. Y-axis now is seminal plasma to blood plasma ratio on a log scale, and this horizontal dashed line just represents a value of 1. So all points below this line suggest non-preferential distribution into the seminal plasma. And for both CAB and Rilpivirine, the seminal plasma to blood plasma ratio is consistently below this value of 1 throughout the dosing interval, and the median seminal plasma to blood plasma ratios mirror what we saw with AUC values, 0.01 for CAB and 0.1 for Rilpivirine. And to put these total concentrations into perspective, we have to understand the protein binding. Both CAB and Rilpivirine are highly protein bound in the blood plasma, demonstrating only 0.1% and 0.2% protein unbound. However, both of these are less protein bound in the seminal plasma. Cabotegravir, 48.4% unbound, and Rilpivirine, 10.4% unbound in the seminal plasma. And now with the total concentrations and our protein unbound percentages, we can estimate the protein unbound concentrations. Once again, we're back to concentration on the y-axis. And now this horizontal dashed line is at the EC50 because this is a more appropriate threshold for unbound drug. Cabotegravir blood plasma, protein unbound blood plasma concentrations remain above the EC50 throughout the dosing interval, but Rilpivirine concentrations, at a majority of time points, the concentrations are below the EC50. And when I overlay the seminal plasma data, we see something vastly different than we saw with total concentrations. Not only do these seminal plasma values exceed the EC50, but exceed the protein unbound blood plasma concentrations throughout the dosing interval, resulting in protein unbound AUC seminal plasma to blood plasma ratios of 4.3 for CAB and 3.5 for Rilpivirine. And to really just drive this home, you recognize this graph from earlier, but when I put the unbound seminal plasma to blood plasma ratios, we see that like total ratios, these are consistent throughout the dosing interval. However, the protein unbound ratios remain above 1 throughout the entire dosing interval. And this suggests, despite the poor penetration of these drugs into the seminal plasma, the lower protein binding in seminal plasma results in greater concentrations of protein unbound pharmacologically active drug in this compartment. So to conclude, total CAB and Rilpivirine seminal plasma concentrations were less than 10% or equal to 10% those in blood plasma throughout the dosing interval. However, protein unbound CAB and Rilpivirine seminal plasma concentrations were greater than 3-fold higher than those in blood plasma throughout the dosing interval. Total CAB and Rilpivirine blood plasma concentrations exceeded PA-IC90 values, and protein unbound CAB and Rilpivirine seminal plasma concentrations exceeded EC50 values throughout the dosing interval. And together, these data suggest that there is adequate exposure of both of these drugs in both compartments. And further studies focusing on the determinants of CAB and Rilpivirine concentrations in the male genital tract throughout the dosing interval are warranted. And with that, I would like to thank my advisor, Dr. Devanathan, the Devanathan Laboratory, our Rust Belt Center for AIDS Research, our small molecule biomarker core, the Certara Academic Center of Excellence at the University of Pittsburgh, and our NIH funding. Thank you.